Are we recording?
We are recording. Right, everyone, welcome to another CPD with Groats. Today I am kindly joined by one of my very good friends, ex-housemate, fellow fellow podcast host.
GT friend as well.
It is the one and only Tom Drinkwater. Thanks for coming on, Tom.
No worries. Thanks very much for inviting me, Mr. Jack Graydon, physio extraordinaire at Guy's and St Thomas's.
Thank you very much.
So I thought I'd be able to do whatever I can to help out the cause of CPD and some continuous professional learning for all of our physio colleagues.
Lovely. So, what are you going to present today for us, please, Tom?
So, hello everyone. My name's Tom. I am a physiotherapist. I work over at HCA Healthcare UK, and so yes, I did have a long stint in the NHS for 5 or 6 years, but then for the last 4 years, I've been over at HCA Healthcare UK in their primary care team, and today I'll be talking about how to manage chronic ankle sprains and instability. So this is an area that's of keen interest of mine after I've sprained both of my ankles countless times, and after actually doing the research and constructing this presentation and providing it a couple of years ago at the HCA Physio Conference at the National Gallery. I very much enjoyed presenting it then, and so I hope you enjoy listening in now.
Right, I can't wait. So hopefully everyone is waiting with bated breath. So off we go. Let's do this.
Okay, here we go. So let's see if the technology works. It does. So the aims and objectives will be to give a little bit of background information on ankle sprains themselves. Don't worry, I won't be insulting your intelligence by going from the very, very ground up. I'll be moving as swiftly on as I can and trying to get stuck into the meaty stuff. And given the format that we have available and the time frame of around 10-15 minutes, of course, I won't be able to cover absolutely everything that there is to talk about in the topic of persistent chronic ankle sprains, but I'll do my best to cover as much ground as I can. I'll move on to talking about some of the evidence base in the area, and then move on to management and rehabilitation in the physiotherapy treatment principles of this cohort of patients. The chronic ankle sprains, why don't they get better? Well, it could be for a number of reasons, and here we have a list of some of the potential factors that could be at play with a patient that's struggling to progress. So perhaps it's something to do with an inaccurate assessment, or the patient being miscommunicated in terms of their prognosis or prognostic factors. Something to do with the communication errors in expectations. So again, kind of tying into that last point, we need to make sure that from the very start we're communicating to our patients about how long we really do think that a rehabilitation process will likely take for an acute ankle sprain. Is it something to do with inadequate rehabilitation? So again, I'll come on in the coming slides to talk about how long it should take for rehabilitation for a sporting individual or a non-sporting individual, or premature return to sport. So with our sporting athletes or our high-level performers, of course, these patients do have a very good baseline level of strength and postural control. But if these patients are getting back to sport too soon, then actually the research does tell us there's a very, very high likelihood and risk of re-injury. And then the last point, this will again tie into that last point I just started talking about, so centrally maintained pain. So of course, I'm aware that we know about all the research that is done into this area, and how we know that central sensitization plays a key role in all of our patients' rehabilitation journeys from the acute phase onwards. But the key thing to ask ourselves is, when managing our patients, do we think that the patient's mood, anxiety, fear of movement, low self-efficacy is playing a key role in blocking their progress? So perhaps if We're using good outcome measures to support this theory. So we'd be looking at the HQ9, the HAD, the hospital anxiety, depression score. And if our patient is scoring highly on these measures alongside some of our other clinical reasoning factors, then certainly we might need to shape or adapt our approach. So taking more of a coaching and counseling style approach to rehabbing these patients, but also thinking about the other options of referring on to other healthcare professionals such as the GP, psychiatrist, psychologist, etc., to help alongside our physio treatment. So what is the problem? Lateral ankle sprains are the most common lower limb injury incurred by sporting participants. Individuals who participate in sports. I can't read. I've just had the little pop-up of the video of Jack and I, so I couldn't read that last few words. So yes, lateral ankle sprains are the most common lower limb injury incurred by individuals who play sport. But also amongst our non-sporting population, it is a very common injury. It's a highly prevalent among the general population of around 70% of the general population sustaining an ankle sprain at some point in their life. And only 50% of those who incur a lateral ankle sprain go on to seek medical attention. So I think this point quite nicely demonstrates how there's a large group of people who are just assuming, rightly or wrongly, that they can know how to instinctively rehab their ankle or their lower limb following an ankle sprain, and therefore this can then move on to the next point, which is lateral ankle sprains have the highest re-injury rate of all lower limb musculoskeletal injuries. So we can see that it's a clear problem that can affect someone's ability to play sport, because they'll be, if they're sustaining more than one injury, then it could potentially develop into more of a chronic issue. An observational study in the USA in 2014 found that the average return to play time in college athletes for new ankle sprains was just 3 days. So I think you'd all agree with me in saying 3 days is probably not long enough to allow for full healing to occur and for full resolution of mechanical and sensory-motor impairments. And then the last point, 40% do go on to develop chronic ankle instability after their first ankle sprain, by Delahunt et al. 2018. So
quite surprisingly high, I'd say. 40%.
So yes, these are quite staggering percentages, and as we can see, there are lots of sports players that will continue to play with an ankle injury, and as I'm going to come on to talk about in the coming slides, there are still some contentious points, or discussion points, I should say, around how to manage someone with multiple ankle sprains, and what should we do about these patients or players or clients, whatever you want to call them. Right, so it is a problem. Yes, it is. But what can we do about it? We need to stay calm. Yes, stay calm. And remember, roast. Roast. So what do I mean by roast? Those of you who are keen physio spods like Jack and I will have looked at the research base and already know what ROAST stands for. It does, of course, stand for Rehabilitation Oriented Assessment. So rehabilitation oriented assessment was a craftily come up with by Delahunt and his team, and this is a really nice infographic produced by those guys, and it's published in BJSM back in 2018.
I'm going to share this infographic for all of our viewers tomorrow on tomorrow's CPD update. So you'll get a copy of this in your Microsoft Teams channel tomorrow.
So access that channel, get on down and have a good read up, so you can have an understanding of what it means. It's basically a nice infographic that illustrates how at each and every stage of treatment and management, we need to be looking at underpinning our choices through a thorough and evidence-based assessment, and not just look at just the basics of just range of movement and strength. We need to also look at accurate swelling measures, self-reported outcomes, perceptions, dynamic and functional testing. Or if we flip it round, we're moving on from that first 10, 15 minutes of assessment. We then need to be thinking carefully about rehabilitation principles and keeping those in mind from the very first moment onwards beyond the assessment. So it's trying to marry and match up those two concepts very nicely, not just thinking of the assessment in isolation and the treatment in isolation. We're merging the two from the start all the way through someone's treatment and rehab journey.
Just before we go on to the next slide, just to be clear, the roast is the letters from rehab orientated assessment.
Sorry, did you just do that, Jack?
No.
I've got no idea what just happened there.
I think that was your computer having a little moment. But yeah, the roast is rehab orientated assessment. So the R, O, and A, and then it uses the S from assessment and the final T. So that's where the roast. What's the word? Synonym? Anagram? What's the
synonym?
The countdown conundrum? Roast. Yeah, 5 letters.
I feel like we're zoning in on the roast aspect a little bit too much. So the idea is basically that you're looking at rehabilitation within the assessment. So try not to just allow the image of a roast dinner to cloud your thought process. It's not anything to do with roasting some meat or potatoes or anything like that. It's to do with matching up the rehabilitation and the assessment process together and trying to merge the two.
Yeah, just while we're on the subject of roast, before we go back onto the serious stuff, what meat would you say your favourite? What meat would you have with your roast?
We're going to need more than 10 minutes to answer deep questions like that, because it all depends on your mood. I personally think that as a reliable high performer, each and every time it's got to be roast beef.
Yeah.
It's done well.
Yeah, that's the key thing. I mean, myself, I'm happy with lamb and mint sauce, but yeah, there you go. Right, please do go on.
Right, where was I? Okay, so how do we make the perfect roast? Just perfect timing for that question, Jack. Thank you. So of course, it's dependent on a number of factors. Thorough assessment. So this means an accurate and reliable assessment, moving down the right path of trying to rule out any differentials. So differentials being any other ankle injury, such as syndesmosis injury, osteochondral injury, osteophyte formation, subchondral cyst, microfracture, tarsal tunnel syndrome, other peripheral nerve injury or tissue involvement or tendon-related pain. I'm hoping that, again, within our time frame, we can't talk about all of these and how to assess for all of these various different differentials, but do go away and start having a look at how to assess accurately for all of these differentials. And if you're suspicious of any of these being present, then you do need to, hit the pause button and get them referred back to either their GP or send them straight on for imaging to rule in or out any of those differentials. Because if you're trying to rehab any of these patients with any of these differentials being present, then you are going to hit a quite significant hurdle that you won't be able to get beyond. So do make sure that the thorough assessment, that's why I'm sort of focusing in so much on that in this presentation, is because this underpins everything that we do. If we get that wrong, then yes, we could be going through 5, 6, 7 sessions with a patient that we think has got a lateral ankle sprain, ATFL grade 2 or 3 tear, when actually there's something else going on, and yeah, you're very you're gonna struggle with them.
Yeah, no, I think that's an excellent point. Sorry, yeah, I think excellent point. And actually, the case study I gave you all yesterday was trying to get you to think as many differentials as you can. Obviously, Tom's just listed quite a few differential diagnoses there, and actually because of the rate of ankle sprains, it's very easy to label this as a, quite a lot of these presentations are lateral ankle sprain. Actually, it's try not to be too tunnel vision in terms of labeling this straight away, and like you said, like being 6 to 7 sessions down the line, and actually the other differential diagnoses haven't been considered. So yeah, definitely a good point there.
And then moving on to our management, just the last point I didn't just talk about was Ottawa ankle rule. So that's one of the other key things we need to be asking ourselves is there a fracture present? So Ottawa ankle rules are a well-documented, fairly reliable set of measures to rule in or out a fracture in an acute ankle presentation. So I don't know in your service as to whether you do get the very acute ones coming through, but if someone talks about having an ankle sprain even a week or two previously, then you can ask them the questions of the Ottawa ankle rule. So you can ask them if they did have bony tenderness in and around the malleolar zones or the midfoot zones, the tarsal zones, and could they weight bear for 4 steps or more immediately after the incident and in the emergency department. So if they're saying yes to any of those things, then actually your suspicion of a fracture being present is of course coming up. And if they haven't had any imaging, X-ray or other imaging for that matter, then you should be asking yourself these questions. Best management during acute phase. So RICE or police. Police is basically just a slightly modernized, fancy way of saying rest, ice, compression, elevation. So P stands for protect, and then OL stands for optimal load, and then ice, compression, elevation. Brace or not to brace. So that's the sort of contentious question I was talking about. So I think this probably will be a discussion point for years to come in all of our physio colleagues. So actually the majority of the research currently does lean towards the use of external bracing or taping in our sporting population for up to 2 years post-injury. So I was quite surprised at the length of time that the research suggests, but it says up to 2 years after injury to provide extra support. The next point, talking about outcome measures. So we definitely need to be using outcome measures to support our reasoning and our thought process, but also just to relay back to a patient as to how they're progressing, because it's all well and good if we're saying things to patients of saying, yes, you are improving, but you're not ready to get back to sport. We need to be able to tell them, yeah, these are the reasons why you can't return to your sport just yet. So using things such as the BEST, the balance error scoring system, the SEBT, the Star Excursion Balance Test, or the FAM, FAAM, foot and ankle ability measure. So that's a questionnaire. Goals. So goals, we need to be making sure that, again, coming back to some of those points I was talking about before around good forms of communication, and making sure that the patient is setting realistic targets for themselves, and we're not just allowing them to be too adventurous or too sort of ahead of the game, thinking that they're going to be getting back to playing sport or high level sport in 1 week or 1 or 2 weeks. We need to be realistic with them. Honest and open discussions on prognosis. So again, that kind of ties into what I've just been talking about. And flexibility and mobility pushed and maintained. So there's a strong link between, not a direct linear correlation, but definitely a strong link between lack of ankle dorsiflexion range and an increased risk of lateral ankle sprain. So from, again, going back to our very first moment that we're seeing the patient in that first session, we need to be looking at knee to wall test, ankle dorsiflexion range, and comparing to uninjured side, and also looking at normative values so we can give our patients, again, clear targets to be reaching along each stage of the rehab process. Hip and proximal stability addressed. So of course, let's not forget about the proximal areas and looking higher up the connective chain. Yes, we're talking very much about the ankle today and in this discussion, but that we've got to make sure we're looking higher up the chain: knee, hip, and the core. So looking at all of these areas in terms of how they influence postural control. Good advice throughout each stage of rehabilitation. Again, that comes back to what we've just been talking about all the way through the piece. We're giving good communication. We're making sure that everything is matched up with what the patient is thinking and what we're thinking. Strength work, so not just concentric exercises, not just heel raises, not just TheraBand work. We're looking at some isometrics as well, some dynamic exercises. Balance and proprioceptive work. Patient and therapist relationship must be strong and harmonious to work effectively, and for patient buy-in, because as I'm sure all of you physios must understand that if we're not providing that enthusiasm and that thorough level of buy-in ourselves, then you can probably guarantee that you're not going to get much buy-in from the patient as well. So we need to make sure that with these patients, they understand that we are fully bought into their rehab process, and they will hopefully then buy into us. And then looking at sport-specific plyometric training and advanced exercises, and not just going through our standard menu of exercises, or going back to just what I was talking about before, not just dishing out a TheraBand or two. It's got to be a little bit more than that. So after the roast, yes, it's rehab time. And there we go. So key principles being, as I've just been mentioning, looking at all factors of postural control, strength, range of movement, balance, dynamic exercises. And then there's a question around how much we should be progressing our patients before we say that they can get back to sport or get back to work. Well, actually, this is a tricky question, which is not so easy to answer in just a few words. But we need to be making sure that we're looking at the tasks that will be typically involved in their sport or in their job and their work. So even our elderly population, we still need to be thinking about what they will be encountering in their day-to-day life. So crossing the street, or turning quickly, or stairs, or stepping down from a curb, or stepping down from steps, and making sure that this is involved in our rehab. Looking at, for those higher level athletes I was just mentioning, high level exercises such as running and stopping on one leg, box jumps, two-legged box jumps, single leg box jumps, dropping and landing, looking at landing mechanics, dropping and then sprinting off, so jumping, landing, and then sprinting off into one direction, jumping lunges, lower limb tasks combined with upper limb tasks, particularly if they're a netball player or rugby player, or hockey players as well. Yes, definitely. So trying to combine not just the lower limb exercises, but looking at that full kinetic chain. I realize I sound a bit like Joe Gibson here, but yes, it is vitally important that we're looking at the whole person as one, and not just looking at the one part of the body that's injured, i.e. the ankle. Oh, and sorry, the last point I've just put here is don't just forget about the inverters. So the tibialis posterior and the ankle inverters are vitally important, because there is some research that suggests a strong association between weakness of the ankle inverters and an increased risk of re-injury of a lateral ankle sprain. So we need to make sure that we're testing and accurately assessing ankle inversion strength and developing that strength too. So at the start, I asked these questions: chronic ankle sprain, what could be the reasons why they're struggling to progress and improve? So could it be an inaccurate assessment? Is the patient educated or misinformed on their prognosis? Are the expectations being discussed fully? Is it to do with an inadequate set of rehabilitation processes? Are they being returned to sport too early, or is it something to do more with a central component? So of course it could be one or multiple of these factors, but hopefully now you can start to think about where, if you reflect on some of your patients that maybe have struggled, some of your ankle patients that have struggled to progress, or you've hit a bit of a sticking point with certain ankle patients, then try and have a think and reflect on those patients as to where you might have gone slightly wrong, or where something you might not have focused in on enough. So now, rather than roast, I've come up with my own little acronym. So PUB, what does PUB mean? It means patient education, unrealistic expectations discussed, and B for buy-in. So we need to make sure we're ticking off all of these areas that have effective treatment and rehabilitation. So once we've got our roast, we could even have the roast in the pub. Why not? Have our roast for a good, accurate assessment, and then move into the pub for our full buy-in with the patient. So the summary: chronic ankle instability is a significant problem. 40% of first-time ankle sprains develop into chronic ankle instability. So yes, it is a big problem. Use our roast rehabilitation-oriented assessment as guidance for a thorough assessment. Treatment and rehabilitation should be based on a thorough clinical assessment, and use the Tom Drinkwater PUB principle: patient education, unrealistic expectations, and buy-in as guidance to rehabilitation. And rehabilitation must be comprehensive and return to sport only when appropriate outcomes are met. We've got some references here, and I'm very happy for Jack to pass on the presentation to you guys if you'd like to have a look back at it.
Thank you so much, Tom. I think there's some really key points, especially if you are struggling to manage these chronic ankle sprains. I think those 6 key points to sort of review when you are looking to see or sort of investigating why they aren't progressing. They're a really good method to see what potentially might need further exploring. So I think fantastic presentation. Thanks so much for giving up your spare time on a Saturday.
It's fine, no, it's all good. We've all got to try and keep ourselves engaged and try and share our knowledge as best we can.
Exactly. And I think hopefully in what we will be doing soon as we can, we'll be applying your PUB principle
Absolutely.
in the pub and out of the pub. So yeah, thank you so much.
Yeah. No worries. And thanks for listening in, guys. I hope there was something to take away from that. And there's plenty more to look at and to keep practicing with our persistent chronic ankle patients. But hopefully you've got a few ideas there to take away.
Right. Thanks, Tom. I will see you soon, and I'll see you all soon on tomorrow's CPD post. Take care, stay safe, stay sanitized.
Nice one. Cheers, guys.